Today, we're going to discuss this condition, which is known as the ataxia, or sometimes it is also considered as an ataxic condition, because basically, primarily, we are dividing the ataxic condition or the symptom of ataxia into two major categories, that is the inherited category and an acquired group of patients. So basically, when we define this condition, any patient who has uncoordinated voluntary muscle movements is said to have ataxia. Now, when I basically mention the word that it is involving the voluntary movements, again, I am focusing on the muscle movements. So it can involve the muscles of the any part of our body. It can include the muscles of our legs, and that is how it is going to affect the gait of the individual. On the other hand, it can be the facial muscles, and whenever the facial muscles are involved, obviously it is going to have an effect on the facial expressions, on the swallowing, on the speech of the patient. And all of these are basically even categorizing or describing the major signs and symptoms that we would be observing in a patient of ataxic condition. So basically, we gather through this information that a patient who comes up to you with a staggered gait and he's entering into your office and you're observing that patient and you're focusing on the gait of that individual, you find that there is some sort of a disturbance that is involving the muscles of the lower limbs and it is affecting the gait of the patient. Then that is basically the point when we can basically say that the patient is suffering from an ataxic gait. Usually when you would be interviewing these patients, there would be a symptom of slurred speech that is quite noticeable in these patients. So while interviewing, you are even going to notice the speech and write down whether it is an interrupted speech that the patient has, whether there is a discerned speech, whether it is a continuous speech, there is a slurring of speech noted down. Whatever it is, you're going to document that down. Your observation has to be very significant over here. Then the ocular movements. Ocular movements are again sometimes paralyzed in these patients of ataxia. So all of these is going to give you a combined clinical picture of a patient who is suffering from ataxic condition. And today we're going to basically study in detail what is causing this ataxic condition, how common is this condition, what is the prognosis in such patients. We're going to discuss all of that over here. That's going to be very interesting, and it is very easy to comprehend ataxic condition when you study the details and you have a command on the basic knowledge regarding the pathophysiology of this condition. So it is going to be quite easy for you to comprehend the condition of the patient and then obviously get a proper treatment plan and management guideline for these patients of ataxic conditions out here. So we have cerebellar ataxia, and we all know that cerebellum is a primary organ which is involved for the coordination of the individual, for a balancing posture of the individual. Cerebellum plays a very important role. When we study the neuroanatomy in detail, we get to know that there are a lot of tracts out there, including the cerebellopontine tracts. Then we have the cerebellomedullary tracts, and all of these are basically gathering information from the medulla, pontine, from the spine, and getting the details jotted down in the cerebellum of the individual regarding the posture and obviously the voluntary movements. So the movements are basically coordinated in action due to the proper functioning of the cerebellum. And in any case, if there is an improper functioning of the cerebellum, or the cerebellum is not working in a proper way, it can basically affect the coordinated movements of the individual. So cerebellum is the major organ out here, and that can be one of the major cause of ataxia when I mention the uncoordinated movements in a patient. Then we have, obviously, we have symmetric ataxia. So depending upon the clinical signs and symptoms, we'd be dividing it into symmetric condition, or either it is affecting only one side, which would be regarded as an asymmetric ataxia or asymmetric condition. The asymmetric condition, or if it is just affecting a single portion of, or single limb of the individual, it can be termed as focal ataxia out here. So these are some of the terminologies which we are going to use when we have these patients and we have already diagnosed them to be suffering from ataxia. We want to really know whether it is affecting both the limbs, whether it is affecting one side of the body, or either it is affecting just the upper limbs or just the lower limbs. So just to know these terminologies, it is going to be very easy for you to describe the patient when you're documenting your findings in a particular patient. So we have another very important group. As I've already mentioned, the two major categories are inherited ataxia, and on the other hand, we have the acquired ataxic conditions. One fact that is linked with the inherited group of disorders is that the prognosis over here in these patients is not very good. So usually they would just come up to their second or third decade of life, and that is the maximum that they can live up to. So this is one thing that is linked up to this group. Then moving on, we have the autosomal dominant ataxias. It is one of the genetic conditions out here. And then we have the autosomal recessive ataxias grouped over here as well. And then we have a group which is known as the mitochondrial ataxias. Usually the groups that are basically mentioned out here regarding the autosomal dominant, recessive, or the mitochondrial ataxias are basically the genetic conditions that we're talking about. So usually they have a genetic background, and when we'll be studying them in detail, then you would come up to know that basically a genetic condition or a genetic alteration and mutation is causing these kind of ataxias in these patients. Then we have the cerebellar ataxias. Now, as I've already mentioned, the fact that cerebellum is an organ which is responsible for the balance and coordination in totality. So basically, it is sending messages to the cerebral cortex as well as the spine for the reflex actions. Now, cerebellum is the organ which is responsible for the balance and coordination in a human body. So if there is any problem relating to this structure, that can result in an imbalance and uncoordinated movements in a human body. Now, what are the causes? Obviously, I'll be talking about the acquired conditions which can result in cerebellar ataxia. Usually, it can be the drugs which are crossing the blood-brain barrier. A lot of drugs are notorious for developing this kind of a condition. Carbamazepine is one of the drugs. Oxcarbamine is one of the drugs which is responsible for crossing the blood-brain barrier and affecting the cerebellum of the individual, and finally resulting in a discoordinated movements, slurred speech, dysarthria, difficulty in swallowing and talking. All of these are basically part and parcel of the cerebellar ataxic conditions. Then a lot of degenerative conditions can occur, and they can basically result in the ataxic conditions of the body, and that is basically it can be even the multiple sclerosis. So the infections, acquired conditions, autoimmune disorders, and tumorous conditions can even affect the working and the functionality of the cerebellum, and obviously result in the overall ataxic condition of the individuals. So this is the overall review and the underlying pathophysiology behind the cerebellar ataxia. Then we talked about a group which is known as symmetric ataxia, and when I say this or when I mention the term symmetric ataxia, by that I mean that it is going to affect both sides of the body in a symmetrical pattern. So again, it can be caused when the cerebellum of an individual is affected. It can even be caused due to the cerebral cortex demyelination due to multiple sclerosis. And all of these demyelinating and degenerative diseases can ultimately result in the ataxic conditions of the individual. So this is going to be the picture in this particular patient. Focal ataxia is basically when one of the lobes is affected. For instance, it can be the frontal lobe. If it is affected, it is going to affect the overall personality of the individual as well. Then we have the temporal lobe, which is again going to affect even the auditory signs and symptoms as well. And then we have the occipital lobe, and when a certain portion of the brain is affected and it is affecting the muscles of the contralateral side, then obviously there is going to be an uncoordinated movement that is observed in this particular patient. So basically, we have this mixed picture, and through the diagnosis, when we carry on further tests, obviously further, we have to first of all examine the patient in detail, and then we have to perform the screening tests. And starting on, the radio imaging is one of the best techniques to find out what is the underlying pathophysiology, what is the underlying cause for a certain ataxic condition. Then obviously we can even perform the blood tests, because a lot of systemic conditions are going to manifest, and you can easily diagnose by conducting the blood tests. And when the blood samples are sent to the pathophysiologist, he or she may explain in a better way what is the underlying cause for the ataxic conditions. Then we have this urine test, and urine samples are again going to explain the systemic conditions in detail. So these are the specific tests, and all in all, we even have to consider the genetic tests that can be conducted for finding out whether it is a form of inherited condition or inherited example of ataxia that is manifesting in this particular patient or not. So this is how basically you diagnose this case. This is how you basically investigate the case in a particular way. And obviously the history is also going to make a lot of explanations. So you have to take the history in detail as well. Any past surgical and medical history, any family history of genetic ataxias, and any drug interactions, any drug history, if he or she has been taking a certain type of, even a prescribed drug for a longer period of time, you have to mention that in your history in detail. So these are some of the causative factors, and even when you're investigating, this is basically you're enlisting the different causes of ataxia while you're taking the history from the patient and while you're examining the patient in detail. So basically the causes and the way in which you're going to examine and take history from the patient is going to go side by side in these particular patients. Now, the etiology of cerebral ataxias, we have symmetric and progressive signs in these patients, dividing them into the acute phase of the ataxia, which basically manifests in hours to days. We have the intoxication, which can occur due to the intake of alcohol. Even it can be the phenytoin, lithium, and barbiturates that are seen for these patients. Then a lot of viral infections. Here I would like to mention some of the very important infectious states known as poliovirus, Coxsackie virus, echovirus, Epstein-Barr virus. All of these are the viral conditions which can manifest as cerebral ataxias, causing cerebritis, and in turn they are causing the uncoordinated and ataxic conditions in the human body. So again, the screening tests which I've already mentioned, performing the blood test is very important over here. Performing the culture test is very important over here, because that is going to signify that there is any ongoing infectious state in the individual or not. And a raised ESR is going to signify that the patient is in a state of infection or inflammation. So it's again very important to focus on these basic tests, and you perform these basic blood tests on the individual, the CBC, that is the complete blood count, and along with that you have to perform the cultures, the ESRs. They are of significant value over here when you're investigating the patient of ataxia. Then there is a syndrome which is known as the post-infectious syndrome, and in this condition, a patient who has a recent history of infection, which can be even told by the patient himself or herself, or even you can look up into the papers if he has been admitted to the hospital in the recent past for some sort of treatment of an infection. That is sometimes related to this post-infectious syndrome in these patients. So these are some of the causes of the acute infectious states. And then we have the sub-acute ataxia, which usually develops in days to weeks. And the weeks, obviously, it can be almost 2 to 3 weeks that it may take to develop. The intoxication can occur with mercury, it can occur with solvents, glue, gasoline, chemotherapeutic drugs. Usually there is a long-term history that is associated with the intake of such intoxicating drugs. And then we have the alcoholic nutritional deficiencies. Finally, we have the Lyme's disease, which is one of the autoimmune disorders and is going to even manifest as ataxic conditions, slurred speech, antisocial behavior. So usually sometimes the intoxications, the use of the illegal drugs, the drug abuse, the drug addiction is sometimes related to the development of Lyme's disease in a lot of patients. So these are some of the signs over here. Then we have the paraneoplastic syndrome, which is one of the conditions which occurs in the tumorous conditions. Patients who are suffering from cancerous conditions usually develop this kind of a syndrome, which is associated with ataxia. Anti-gliadin antibody syndrome is one of the conditions. It is a metabolic disorder. Phenytoin toxicity is one of the conditions. Hypothyroidism is one of the endocrine conditions which can be related to the ataxic conditions. So it can be even an undiagnosed case of hypothyroidism. Usually the patient sometimes present to you with ataxia and he or she doesn't know that he's suffering from or she's suffering from hypothyroidism. When you run these tests and when you set the blood samples, that is going to finally evaluate the systemic conditions resulting in ataxic conditions. So this is again very important over here. And then finally we have the inherited diseases. A lot of inherited conditions are basically resulting in the ataxic conditions. So we'll be going through the spinocerebellar disorders ranging from almost 1 to 7 of their phenotypes. And we'll be discussing these genetic conditions, how they manifest as ataxic conditions in the individuals. Then we have the focal and the ipsilateral cerebellar signs. So in a lot of states, you have the focal conditions affecting only one side of the body. So how are they going to present? In acute states, that is developing within hours to days, subacute, and then we have the chronic phases of this condition. When I say it's developing in between almost hours to days, it's basically a lot of conditions are vascular in nature. For instance, we have the cerebellar infarction, the hemorrhage, or it can be a subdural hematoma. Now, even the underlying causes are quite different over here. So sometimes we may not know what is the causative factor over here. Then finally, we have the infectious statuses. For instance, we have the cerebellar abscesses. The subacute developing between days to week, we have the neoplastic conditions. Most notoriously, we have the cerebellar gliomas. And then we have tumors metastasizing to the cerebellum from the kidneys, from the livers and lung. Then we have the demyelinating disorders. As I've already mentioned, multiple sclerosis is very significant of them all. Acquired immune deficiency syndrome related multifocal leukoencephalopathy develops usually between days to weeks, and then it is quite difficult and the prognosis is not very good even in these cases. The stable gliosis, which is secondary to vascular lesions, we have to mention it in the category of chronically developing symptoms of ataxia. And then we have the congenital lesions. For instance, we have the Dandy-Walker malformations or the Chiari's malformations, which are again vascular in nature. So this is one of the these are one of the conditions. Basically, these are that are mentioned over here. And in these kind of conditions, the symptoms are focal and they are ipsilateral in their nature. So it is basically happening like that, but basically when it is affecting one of the lobes of the cerebellum, it is going to have the symptoms on the contralateral side. So this is the focal individual development of symptoms over here in the patient. Now, when we talk about the inherited ataxic conditions, we have the autosomal dominant ataxic conditions, mitochondrial ataxias, and then we have the autosomal recessive conditions, which again manifest as ataxias. So either it is a dominant or a recessive or a mitochondrial condition, it is going to have a genetic background over here. These symptoms are going to be basically in inherited ataxias, we are going to have the symptoms of the basal ganglia when they are affected by any other event disorders. For instance, there is some sort of an infarction, trauma, and infectious states, and it's affecting the basal ganglia. The symptoms are going to resemble that condition even over here. Then we have the brainstem disorders. Brainstem is basically involving the medulla, the pons, the midbrain, and all of the conditions in which the brainstem is involved, it is going to be affected even in the inherited ataxic conditions over here. Then the spinal cords, is also going to be affected in such a case, because all of the ascending and the descending tracts can be involved in these cases of inherited ataxic conditions. The optic nerve disorders, because as all of the cranial nerves can be involved, cranial nerves are mostly coming out of the brainstem. They're exiting through the brainstem. So all of the cranial nerves can be involved, and specifically the optic nerve can be involved over here. And we all know that optic nerve is basically responsible for the extraocular movements out here. So it can be one of the conditions. And then we have the peripheral nerve disorders, and then we have the cerebellar manifestations that are quite importantly seen over here, manifested in gait, speech, movements of the eye that can basically be seen that they're affected in such conditions. Then we have the basal ganglia syndrome. This is because whenever the basal ganglia are involved, that is basically going to manifest in these conditions of the inherited ataxias particularly. Now, talking about the autosomal dominant ataxias, we have these varieties known as the spinocerebellar ataxia 1. Then we have 2, and then we have a third variety that is basically included over here. When we say that there is a third variety, it is again subdivided into 3 subcategories, and that is why after this spinocerebellar ataxia 3, we have the counting jumped up to spinocerebellar ataxia 6, because the 3 has the underlying subdivisions, 3 subdivisions that are basically known as the Makaro-Joseph's disease. So we have 3 subdivisions to this spinocerebellar ataxia, and the third variety is subdivided into 3 categories over here. Then we have the spinocerebellar ataxia 6, 7, and 8 over here. And then finally we have the different category which is known as the DRPLA. And then finally we have the another variety which manifests in episodes. It is not a continuous condition. It usually manifests in the episodic period. Sometimes it is present and sometimes it vanishes away. So this is how you categorize the autosomal dominant ataxias, and the most important, as you can even see and notice down over here, is the spinocerebellar ataxia, which is almost 8 varieties. So when we talk about the spinocerebellar ataxia 1, basically there are sign and symptoms that the predominant sign and symptoms over here is the dysarthria and the dysphagia. That is quite predominant over here. And even then we have the oculomotor facial palsies, which are associated with this kind of a condition of the spinocerebellar ataxia 1. The symptoms include the impairment of equilibrium, mentioning we have the slowness of voluntary movements, and then the speech, as I've already mentioned, there is dysarthria. So the scanning of speech is even affected in these patients of spinocerebellar ataxia 1. We have the nystagmoid eye movements. As we all know, that is the oculomotor nerve is involved mainly in these cases. So the extraocular movements are going to be affected at all in these patients. There are fine tremors of the head and neck and that are noted down. Then there is a difficulty in speech. There is a difficulty in swallowing known as dysphagia. And then we have facial palsies. Noted down. It can be a Bell's palsy kind of a syndrome. There can be a drooping of the angle of the jaw affecting one side of the face, depending upon which of the cranial nerves is affected. So there's going to be this complete clinical picture which is seen in these patients. The extrapyramidal symptoms would include a rigidity, an immobile face, Parkinsonian-like syndrome, and then we have the knee jerks which are lost or they are diminished when you manifest these reflexes, and finally we have the extensor plantar responses noted down. Dementia, loss of memory is also associated with it. And then finally, we have the impairment of the sphincter function. There is going to be uncontrolled bladder or bowel movements associated with it. Cerebellar and brainstem atrophy is also noted down over here. And then we have the loss of the pigmentation of the cells. And finally, we have the spinocerebellar tracts that can be even visualized when we carry out the radio imaging for these patients. So this is again the group of symptoms which are known as the extrapyramidal group of symptoms. The postmortems, and when we conduct these postmortems in detail, on inspection, we're going to find out that there is shrinkage of the pons. As I've already mentioned, there is a degenerative process going on in these inherited cases, which is coupled up with the disappearance of the olivary eminence. As all of these structures are diminishing and degenerating, it is obviously going to be associated with the atrophy of the cerebellum in a complete view. Now, the histological examinations which reveal that there is a loss of the Purkinje cell fibers, a reduced cell in the granular layer, cerebellar demyelination is also noted down, and along with that we have the loss of cells in the pontine nuclei. The diagnosis is completely based on the atrophic changes that are seen on the radiological imaging techniques. When you carry out the CT scans and MRIs, you're going to note down the atrophy that is noted down in the sulci and the gyri of the cerebral cortex or even the cerebellum in these patients. The spinocerebellar variety type 2 is associated again with the extrapyramidal symptoms. The CAG proteins are going to repeat itself in the genetic mutations, and that is the underlying pathology over here in the second variety of the spinocerebellar ataxias. The symptoms would include a slow saccadic eye movement that is observed when you carry out the extraocular movements in all of the cardinal directions. The patient is going to perform, sometimes the patient is going to be unable to perform these movements. There is even nystagmus noted down when you perform these cardinal movements in these patients. Ataxia is one of the the primary symptom that we're talking about. Dysarthria is the difficulty in speech, and then we have the rigidity, which is going to be a cogwheel rigidity. Parkinson's disease is associated with a cogwheel type of rigidity. When you perform movements, there is going to be an interruption between the movements, and that is basically regarded to as the cogwheel rigidity in these patients. The optic disc is going to show pallor, then there is going to be mild spasticity noted down, and sometimes it is coupled up with the retinal degenerations as well. The third variety is known as the Makary-Joseph's disease, and as I've already told you, it is divided into 3 subcategories over here. So the spinocerebellar ataxia symptoms of the first type of the MGD over here are the neurological deficits that are going to appear in these patients. Again, those signs and symptoms of rigidity and spasticity are going to be noted down. The patient is going to have dystonia in the muscles. Ankle clonus is going to be present. There's going to be a stiff gait when you observe in detail, pharyngeal weakness, and also dysphagia, known as, which is basically known as the difficulty in swallowing over here. The patient is going to suffer from vertical nystagmus rather than horizontal nystagmus in this third variety of spinocerebellar ataxias. Now, the symptoms of this patient would be an impairment of the upward vertical gaze, facial fasciculations. Small twitching movements are basically known as fasciculations in these patients. Facial myokymia, and basically the distortions are known as myokymia. Lingual fasciculations, again twitching movements in the tongue. And we have the ophthalmoparesis, that is, the ocular movements are going to be disrupted. And then we have the ocular prominences. For instance, any mass can be noted down when you examine the cornea and the sclera of the patient in the proper light arrangements. Then we have the symptoms of the type 2 for the third variety. So it's basically a subdivision of the third variety. This is the second type of the third variety. Dysarthria involves the difficulty in speech, gait is affected, ataxia is going to be again present along with spasticity, rigidity, dystonia, and that is again going to be coupled with the disruption of the ocular movements known as ophthalmoparesis. Due to the effects on the optic nerve, and the upward gaze is going to be even affected when there is going to be an ophthalmoparesis noted down in these patients. The third variety of the MGDs is the ataxic amyotrophic variety, in which again we're going to observe dysarthria, gait is going to be disturbed, ataxia is present, sensory loss. Along with that, we have the distal atrophy, which is noted down, and then the patient is also going to have peripheral neuropathy in this particular case. The pathological findings would include a neuronal loss, which is going to be seen in the dentate nucleus, corpus striatum, which is one of the important basically interlinking fiber between the two cerebral cortices is also going to be affected, and then we have the substantia nigra, which is one of the most important constituents of the basal ganglia. So all of these are going to be affected in this neuronal loss. Basically, whole of the brain and all of the communicating fibers can be affected in this particular case. The loss of Purkinje cell fibers is noted down in the dentate nucleus, cerebellar cortex, and the cranial nerve nuclei specifically. Now we have the sixth variety over here. The gene involved is the CACNA1 mutation, and the CAG is going to repeat itself over here. The missense mutations are noted down, and then we have the nonsense mutations. When we say there is a missense mutations, basically there is a familial hemiplegic migraine. This is going to be the common sign and symptom over here. And then in a complete nonsense, or in the complete mutation of this CAG gene, there is going to be a paroxysmal cerebellar ataxia that is noted down. So this is how it is going to manifest. The genetic mutations are going to manifest, even the clinical signs and symptoms are going to be different in these particular patients. Whatever the case is, it is going to result in the cerebellar atrophy, and finally, obviously, it is going to result in an imbalance and the uncoordinated movements in the patients. The seventh variety is basically regarded as when we have the retinal pigmentary degeneration. Blue-yellow color blindness is noted down in these patients. The patients also complain of macular degeneration. ophthalmoparesis. Then we have the extensor plantar responses. When you carry out the Babinski's sign, it is going to be present in these patients. Anticipation, anxiety, and they're going to also suffer from the ataxin 7 aggregates noted down. So histologically, even you can even diagnose this particular 7th variety of the spinocerebellar ataxias. Then we have the 8th variety, which is going to manifest itself due to the repetition of the expansion of the CTG gene. The chromosome involved over here is the 13q21. The dominant toxic effects at RNA levels are noted down, and that is going to manifest as the myotonic dystrophy. So muscle dystrophy is the predominant sign over here, which is going to affect the speech, resulting in dysarthria. The gait is affected. Nystagmus is noted down in the ocular movements. Leg spasticity, reduced vibratory sensations, and no ambulation. So the movement is even going to be affected over here. Then the cerebellar atrophy is the primary sign that is noted down in these patients. The dentorubropallidocine atrophy is one of the very major variety over here in the cases of the autosomal dominant ataxias. The underlying pathology is an unstable CAG repeat gene. Atrophin gene is affected in return, and the chromosome involved over here is the 12p12ter. Then we have the progressive ataxia, which is associated with it. Along with that, the patient is going to have the discoordinated movements, involuntary actions, which are known as the chorioathetosis, specifically in the upper limbs. It can even involve the lower limbs. Dystonia is one of the important features. Seizures, it can be the tonic-clonic kind of seizures. Myoclonus is one of the important feature over here. Dementia is sometimes associated with it, and then we have the features of anxiety and anticipation, which are also noted down in these particular patients. Episodic ataxia is one of the very important variant over here. It's basically not a continuous phenomena that is present. It is again subdivided into type 1 and type 2 over here. In type 1, we have the brief episodes of ataxia, while type 2 has larger episodes. There is myokymia and nystagmus noted down in type 1 and nystagmus in type 2. Type 1 only lasts for a few minutes, and type 2 lasts for hours, and even it can last for days. Type 1 induces by posture changes and exercise, and type 2 is induced by stress, exercise, or even the excessive fatigue. Acetazolamide or anticonvulsants may be therapeutic for type 1. Acetazolamide may be therapeutic for type 2. So basically the duration of the episode is how we subdivide these episodic ataxias furthermore into type 1 and type 2. Then we have the Friedreich's ataxia. It's one of the genetic variety as well, and it has its specific features out here. The pathological sites involved are the spinal cord, specifically the dorsal root ganglion is affected in these cases and can even involve the peripheral nerves. The symptoms included in Friedreich's ataxia are the staggering gait. The patient, when he walks in, would have a discoordinated gait. That is quite important over here. That is going to be manifested in the frequent following. Because of the vertigo and the uncoordination that he or she is suffering from, he is going to give you a history of frequent falling in this particular case. Tibutation is basically the tremors of the head and trunk. These fine tremors are noted down in these cases of Friedreich's ataxia particularly. Then we have the dysarthria, that is the difficulty in speech, progressive scoliosis, that is a deviation of the spine that is sometimes associated genetically with such patients. Foot deformities are noted down. Then we have continuous nystagmus that is noted down, and oscillatory movements of the pupil. If the ocular movements are performed in the 6 cardinal directions, Then cardiopathy, on further investigations, you're going to note down that the patient is suffering from a certain kind of a cardiomyopathy, specifically over here. There is going to be a loss of saccadic eye movements. Dysmetria is also noted down in these particular patients of Friedreich's ataxia symptoms. So this is going to be a complete group of symptoms or clinical features that is noted down over here. The cardiac symptoms, particularly in this specific case over here that are noted down, are the fibromuscular dysplasia. Then there's going to be a mycotic hypertrophy. Mycotopathy is one of the feature over here. And then we have the cardiomegaly. There's going to be an enlargement in the size, overall size of the heart, which is going to be a hypertrophy of the muscles of the heart. The symmetric hypertrophy is noted down. This hypertrophy is going to be symmetric in nature, so there's going to be an overall enlargement of the cardiac tissue rather than a particular atrium or a particular ventricle is involved in this particular case. Murmurs, that is the additional sounds when you auscultate the heart. You're going to note down the particular atrial and valvular murmurs in this case of Friedreich's ataxia. Then the patient is also suffer from conduction defects in cases of Friedreich's ataxia. The musculoskeletal symptoms are also noted down. The group of symptoms include the pes cavus, and then we have the equinovarus. These are the kind of deformities noted down in the skull and the spine. Scoliosis is basically the deviation of the spine towards one side. It's basically a longitudinal deviation that is noted down when you carry out the radiological imaging. You diagnose this particular scoliosis in the patient. Atrophy of the cerebellum is also noted down. Then the patient is suffering from an overall muscular degeneration. So there is going to be an atrophy of the skeletal muscles that is noted down when you examine the patient in detail over here. Then sclerosis, so multiple sclerosis is one of the phenomena that is seen over here. The cerebellar symptoms would include the degeneration of the glossopharyngeal, vagus, hypoglossal and deep cerebellar nuclei, and then we have the deep cerebral nuclei. So these are one of the degenerative processes noted down in the 9th, 10th and 11th cranial nerve. Loss of the bed cells in the precentral gyri. Mental retardation is one of the predominant feature over here, and that is associated with the psychiatric syndromes. The ataxia telangiectasias, in which there are the genetic development of the malformations of the vessels, is one of the feature over here. The symptoms would include the cerebral function loss, nystagmus, limb ataxia, difficulty in speech, plantar responses such as the Babinski sign are present, myoclonic jerks, and there is going to be a loss of reflexes noted down. Distal sensory deficits are found. Pulmonary infections are more, basically these patients are more prone to the development of pulmonary infections, neoplasms and thymic hypoplasias. The patient is also going to suffer from premature aging. When you examine the skin of such patients, you're going to notice down these signs. The type 1 diabetes mellitus, lymphomas, Hodgkin's disease, acute T-cell leukemias, breast cancers, loss of Purkinje cells and neuronal loss. It is also associated with the absence of thymus gland. So this is again a group of symptoms that is associated with it, and basically the patients are more prone to the development of all of these particular conditions out here. The mitochondrial ataxias are also included with a variety of the spinocerebellar syndrome. The treatment for the ataxic disorders, basically it includes the immunotherapy. If it's the multiple sclerosis that is the underlying cause, we have to give the immunotherapy to the patient. You usually advise a gluten-free diet to these patients. Vitamin E therapy proves to be very beneficial for such patients. Vitamin B12 is advised. Along with that, you prescribe an antibiotic to cover some sort of superimposed infections, and sometimes you also basically give out, and you want to give out this antibiotics therapy or the antibiotic treatment as a prophylactic treatment for such patients. You ask the patient to avoid alcohol and phenytoin, glutamate antagonist riluzole. And then you also can prescribe acetazolamide as one of the drug in the treatment guidelines. So these are this is a complete regimen that is advised for such patients, and basically it is an antibiotic therapy coupled up with the vitamin therapy, which gives you very good results in these patients of ataxic conditions. So in this particular lecture, we went through the different causative factors that we usually can encounter in our outpatient departments, and we must know how to diagnose the underlying pathology in these cases of ataxic conditions, and obviously make out a management plan for such patients. So that is the end to this lecture. Thank you for watching sqadia.com.